People always ask me, Jeff, how do you work on a tail rotor assembly? And I tell them, I don't know. I'm not a mechanic. And to be honest with you, my name's not even Jeff. My name is Dylan. And what I do know is that we've had a really busy and good year of monthly education for the last 11 months here at CareFlight. So for this December, instead of introducing a new topic and new education, we're just gonna do a quick little review, a year in review of the last 11 months of education, go over some highlighted points, some key takeaways we want everybody to remember, and maybe address some topics that we didn't do a super great job on the first time around. Hope you guys enjoyed this video. Welcome. So starting us off, first month of the year was January, where we did vent scenarios. There was no video or really education to go along with that. Everyone just downloaded that Hamilton Vent Trainer app, and we gave you a couple scenarios to run through and practice optimizing different patient situations. One of them was an ARDS. I think there was three actually. An ARDS patient, a COPD, and an asthmatic. Some of the main takeaways, we're not going to rehash all of it. Some of the main takeaways from that were the utilization of that RCEXP feedback parameter that we get. And just remember that that's just a measure of resistance and compliance multiplied together. And really the way that we use that is we take that value and we multiply it by 3. So let's say that the patient that you have has an RCEXP of 0.5. We're going to multiply that by 3, get 1.5, and that's how long that patient's E time or expiratory time should be. So for the patient with RCEXP of 0.5, we want to give them an expiratory time of at least 1.5. Going beyond that doesn't help us at all. But if you go below that 1.5 E time, then you're going to start running into auto peeping, dynamic hyperinflation, air trapping, whatever you want to call it. Of course, if that happens, you recognize it. You can pop the vent off the tube for a second, manually decompress, get that air out, and go back on, just draw out your E time. Of course, remember that for patients with ARDS or poor compliance states in general from whatever it's from, the major concerns there, or the main strategy for that is going to be higher respiratory rate and lower tidal volumes. You still want to be able to achieve a normal, or even if necessary, higher than normal minute ventilation, but you have to make sure that you're keeping your pressures within under control. Preferably, you want your PIPs and your plateau pressures both less than 30, because that's obviously what we know to be the most protective and the best thing for keeping lungs healthy. If you have an asthmatic or a COPD patient, we treat these fairly similarly. One is a compliance issue and one is a resistance issue, but both patients can have a mix of both, right? Either way, what matters for them is having enough expiratory time. So that's really where finding that RCEXP value is super important and comes into play. You want to find that and make sure that you are giving them enough E time for that high RCEXP that they're most likely going to have. Because the main concern for those patients is they're just not able to get the breaths out. Either the asthma means that the airway is so tight that air just can't move past it fast enough, or with a COPD patient with severe emphysema, the lungs just don't recoil. They don't collapse back down to force the air out. And if the patient's not breathing spontaneously and bearing down, and obviously they're on the ventilator, so they're not breathing spontaneously, we can't force that air out every single breath unless you're manually decompressing between every single breath. Beyond that, other main takeaways is just remember that the most important things that we really want to be within normal parameters or within normal limits for the ventilated patient are your pulse ox, your oxygen saturation, right, your CO2 levels, and then your airway and alveolar pressures. Everything else has a normal range, but sometimes we have to break those ranges to get pressures normal, to get oxygen levels normal, and to get CO2 normal. So for example, if I tell you that normal minute ventilation is 4 to 8 liters a minute, that doesn't mean that with a patient that's in DKA or having some other hypoventilation issues or metabolic acidosis that we need to compensate for, it's okay to break that 4 to 8 liters a minute, right? And give them a higher minute ventilation outside of normal range, because we're doing that to keep their saturations, their pressures, and their CO2 levels within normal.
So the first one I want to talk about is a case that I saw when I first started. Got a call from Dallas Fire Rescue. We're bringing in a guy who was spraying the roses, and now he is extremely bradycardic. He's got diarrhea. He's salivating all over the place. We'll be there in 10. 10 minutes pass, 12 minutes pass, the box pulls up, and nobody gets out. And one of the nurses goes out, and one of the Dallas medics is sitting on a bedpan. doing you know what. And come to find out, this guy was organophosphate. If you take the blood pressure or touch the patient without any gloves, it's rapidly absorbed. So we now have 2 patients from spraying rose bushes. And that's called organophosphates. And the mnemonic is sludge: salivation, lacrimation, urination, defecation. You got to steer clear of these people. Don't touch them. The treatment is very interesting. The treatment is atropine in humongous doses. That's where you get a hold of the pharmacist and say, how much do we have in the building? And you start with atropine, and then we break it up into muscarinic and nicotinic, what effects. And these people are pretty profoundly diaphoretic. They got a pulse of 20. They got terrible diarrhea. They're altered mental status, and you don't want to become a patient with organophosphates. We can't go anywhere without talking about calcium channel blockers and beta blockers. And again, the literature has something every month with these, and we all deal with it, whether it's iatrogenic or a legitimate overdose or someone just doesn't know. And they lump them together because it's easier to remember how to treat them because they're treated the same way. The problem with calcium channel blockers, specifically more so because it's a negative ionotrope and a negative chronotrope, where whatever beta blocker you may be on, we don't know, are you going for eye drops that have beta blockers? Are you going for hypertension? Are you going for whatever issue? This is a class of drugs where it is very much so something that people just cringe when they talk about, and that is charcoal. Charcoal absorbs anything that's non-ionic. So for calcium channel blockers and beta blockers that we're not quite there, that they're sicker than you know what, charcoal absorbs these drugs rather rapidly, especially if they're taking one that forms bezoars in the gut. In other words, there's a huge, 25 metoprolol pills in their gut. We know that charcoal works. Are we going to use charcoal in the field? No. I usually assign the administration of charcoal to an intern. If you get it on you or your lab coat or on the wall, it's there for eternity. But that's the rationale behind charcoal with these people, is it does absorb it and converts it. So we've got a couple of new things that some things are working, some things are not working. What is the issue with glucagon with these drugs? So glucagon with beta blockers and calcium channel blockers, if you just Google that and say, does glucagon works? The answer is could be, but there's better options. And again, the problem is intractable vomiting with glucagon. So we went to intralipid therapy, and it was used for a while as an exchange for that. You literally, the intralipid therapy is given IV, and it would exchange for those 2 agents. Kind of had equivocal results with that. And so lo and behold, what do we find? Insulin and glucose work for calcium channel blockers and beta blockers. It's kind of scary when you look at the dose because it's around 1.5 per kilo of insulin, and then either a D10 or a D20 drip, whatever you want, because obviously they become quite insulinemic with those. So it's high dose insulin and moderate dose glucose that's used in these people. Very, very important, but it works, and it works very well. We're not sure if these 2 agents are very dialysable, as we talked about from the very beginning. What's their protein binding nature, and can you dialyze them off?
So during the month of March, we did hemorrhage control, management of bleeding, and it was mostly related to the trauma patient. But of course, a lot of it can apply to the medical hemorrhaging patient as well. In reviewing the quiz questions for that, performance overall was super great because all of us have, at this point, a pretty decent amount of experience managing, traumatic injuries. The only one that I think is worth addressing that, had a little bit of a miss rate was how long to hold pressure after packing a wound, either with or without a hemostatic agent. So let's say you have a penetrating injury, maybe a gunshot wound, just an entry, no exit to a lower extremity that's bleeding on you. We're going to pack it as we know, going all the way through using our Z-folded gauze. If you have a gauze that is impregnated with the hemostatic agent or you use something else, you're going to hold pressure for 3 minutes on that. Versus if you're just using dry gauze with no hemostatic agents, you want to hold pressure for 5 minutes directly after packing, okay? It's a full 5 minutes after you've already packed the wound of just holding direct pressure to make sure that you build up a good solid clot and it doesn't start hemorrhaging on you again. Again, beyond that, performance is super great, so nothing else really to talk about there. The other topic that I think is of note that's worthwhile discussing from that video is the use of an improvised junctional tourniquet. Because we don't carry actual brand named purpose-built junctional tourniquets here, every now and then if you run into, for example, in the video we showed an inguinal gunshot wound, that's gonna be pretty hard to put some kind of tourniquet on, or just occlude and stop hemorrhaging, besides just being able to peck it. Super big person, you can't get all the way down through the thigh to be able to occlude that vessel directly. You got to figure something else out. So luckily, we do carry on the helicopter here the necessary supplies to make something that's improvised. That is namely going to be a pelvic binder, a 1 liter bag of NS or LR, and then a pressure bag for that bag of fluids. What you're going to do, we have the video playing over my face, and so you can see it all. I'm just going to describe it for you. Is you take that, put the bag of fluids inside of the pressure bag, and do not inflate it yet. You just want to have it in there. Put that bag directly over the inguinal fold, and then wrap the pelvic binder up and around, as you're seeing in the video here. Then once you have that secured nice and tight, if you have a pair of hemostats as well, these can be super helpful, because as you start to inflate your pressure bag, it's going to want to squirt out the bottom of the pelvic binder. So if you can use your hemostats or some other kind of clamp, whatever you have, to secure it to the pelvic binder, as you inflate that pressure bag, it won't squirt out the bottom, and it'll stay right there and just apply some really nice direct pressure to that wound, hopefully for you. Last other thing is, of course, something that we've heard 1,000,000 times, and I just want to keep reiterating as much as I possibly can, and that is to keep your patients warm, your traumatic patients warm, no matter the time of the year. If it's less than body temperature outside, or if they're sweating, they're going to be losing body heat, right? Especially if they're hemorrhaging. So keep them warm. Use the cocoons that we keep back here that we have always readily available. And then don't forget about whole blood, the beautiful whole blood products that we now have rather than packed red blood cells, because that has all of the plasma, all of the clotting factors, everything we need to be able to correct bleeding, even in the medical patient who is potentially already anticoagulated from some other type of medication. Next up, let's move on to April. We're going to talk about management of Impellas and balloon pumps in the transport setting, and we're just going to play some clips from that month's education.
All right. Before we can take a balloon pump call, we need to make sure we do our pre-op checks, and we need to make sure that our bag is fully stocked and everything. So I'm going to go ahead and turn the balloon pump on right here with this green button, making sure that, because it takes a minute to warm up while we go through the bag. All right. So here, Dallas, you're going to see this bag right here. This is the go bag that you can take with you. In the back, very, very back, it has a checklist. So on the checklist, it's kind of beat up, but it has all different types of things that you can do. It tells you where everything is and what sizes, if you end up having to plug things in. So this is really pretty much a quick reference for those who don't do balloon pumps a lot. Inside the bag, you're going to find in the very, very back, you're going to find some extra tubings on the helium. You're going to find that's just the balloon pump. You're going to find Arvin setup, you're going to find straps, extra helium in the bottom. You're also going to find a plug, an inverter, things like that, so you can use to actually plug this in. In the front, you're going to find extra cords, extra cables, so these are the cables that you use. You're also going to find an extra art line setup. And then in a later lecture, we're going to show you a little bit about how to splice in. These are adapters that adapt to different types of pumps. On the side, you also have syringes, you have extra manifolds, and this is so that if the balloon pump fails, you can put a stopcock on and you can inflate and deflate the balloon manually. On the other side, just a pressure bag, because we'll need that. If you don't have a fiber optic cable, then you're going to be going off of art line, so make sure you have a pressure bag, art line setup, art line clip, everything. All right, so that's the bag. All right, so we're going to turn our attention over here to the balloon pump. It turned on, which is great. One of the things we want to do is I'm going to turn this around. On the back, you can see that the battery is charging, so it is charging. Notice this helium, this doesn't work. So it's going to show 0, so we'll show you kind of where to find that on the actual balloon pump. On the front, this is where you would look here. So the helium, it will show low. So when I unplug it to do the test to make sure it works off the battery, I'll show you what that is. Down on the bottom, you want to look at the bottom, making sure that these are the batteries here. So these batteries will come out when you pop them out. So you just turn that this way, this battery comes out, try it the other way, and the other battery comes out. All right, so down here, you're going to see a lock. There's a handle here. That's going to release it. Pull that out. That'll come out like that. Once you pull this out, this is the part where the monitor will hook on. Show you that later. Now you can see the helium shows and it's up. So we want to make sure we do all these pre-op checks, make sure that it's working. It's working off of battery power. The batteries are good. Everything is charging. Everything is working, so that we can mark that on the list up in the room, and you're good to go to take a call. All right, so this is the balloon pump mount. Just going to show you really quickly how to put this in. So as you can see on the bottom, I'm going to show you, there's these two little feet that are right here. Actually, there's 4 feet, and then there's 2 little locks. That goes with these right here, okay? So when we put this balloon pump in, we're going to kind of go here. We want it to go into these little spots, those little feet that I showed you go in. We're going to slide it up pretty much even with the door. The reason why we want to do that is because think about where the balloon pump is on the patient. It's going to be in the groin. So we want to make sure that we have as much slack as possible and not make those cables tight. So next thing we're going to do is once we have it in here, we're going to turn this and get it kind of at the side. Take that. And then now it's locked in. Same thing here. Those turn and click in. And then I usually pull it like that so that way it's locked in. So we're just going to go through the process of loading and show you kind of how this would work, how it goes into the mount, and some of the things that we're going to do as we're kind of getting the patient in. All right. All right, so ideally we're going to have this balloon pump over here on this side right here. The reason why you'll see is because the balloon pump is on the patient's left when you get to the 429. See, it's kind of not a fast process. All right, making sure that line management is super important. So someone needs to be holding this line at all times. This is kind of your lifeline. And one thing to remember is that most of the time these patients are pretty stable once they're on the balloon pump. Now, the biggest problem that we have is not necessarily the management of the patient in this moment. It's the management of the lines and the management of the pump itself. So once we have the patient in, we have our vent, everything like this, monitors here. We're going to kind of just slowly go in and lift up. I'm going to make sure that this balloon pump comes up like this. We're going to kind of load from here.
Okay, you ready?
Yep. So watching the line the entire time, making sure all of that is. And as you can see, this is why it's important to sometimes have like a third person. All right, put you there. I'm going to go ahead and lift this balloon pump.
Jay, to get the, somebody needs to go around front, but just wonder.
All right.
I'll get the balloon pump.
All right, if you've got the balloon pump, I'm going to grab the vent. So as you can see, it's a pretty tight fit with the balloon pump and the mount. So we're going to pop the ventilator off, making sure it doesn't come off on the patient. We're going to put this up here where the next mount like it's supposed to. And then I'm going to come around here, back around, and see if I can get the balloon pump lifted. It's another reason why it's important to have a third person so that they can help you lift this. It's not super heavy, but it's not light. Lift this up right like this. Now collapse it down. Forward it like that. Just like this. Next thing I'm going to do is go back inside. As you can see, it's not an easy process. Right, Brian needs to step for it. Let's just help you lift up and over, watching the lines. So, there we go. Make sure the balloon pump is seated down here. You can tell because it's right on this edge. You're going to lift this little latch right here. It's going to come up. You might have to move the balloon pump back a little bit, and you're going to screw down to basically tighten it in. And at that point, you can kind of shake it, making sure that it's good.
All right, so that was April. May was a freebie, no education, nothing to talk about there. We're going to move on to June. During the month of June, we had some great education on liver diseases. That was a podcast only with no video, so we're not going to have anything to put in here. We're not going to make you just listen to some black audio again. That was put together very nicely by Aaron Vidal. RIP, I want to pull one out for the homie. And Syl Parkinson, who luckily is still with us. So they had a good conversation with a couple different case studies on management of different types of liver diseases, whether it's GI bleeds or Tylenol overdoses. Pretty complex topics and can be pretty difficult to manage. You know, of course, not all of it is directly applicable, or at least something that we can directly intervene on in the transport setting in a helicopter. But of course, I think very worthwhile education and definitely worth going back and listening to if you ever get the itch for that. Just two things that I want to talk about that I think are super important from that month's education. One is super simple, and that's just the recommendation to avoid the use of TXA in patients with GI bleeds. Study, I think in 2020 was the year, called the HALT-IT trial. We'll put it up here on screen for you to take a quick look at. Basically showed no recommendation, no benefit for the use of TXA in GI bleed patients. And specifically if they are cirrhotic and the GI bleed is caused by or related to cirrhosis, TXA can even worsen hemorrhage, not worsen hemorrhage, but worsen outcomes. So a little tidbit of information for you there to remember, to be careful giving TXA if you're suspecting GI bleeds for these patients. I think the biggest point of conversation that we've all had multiple times at CareFlight at this point over the last year or so since this protocol came out is our management of the upper GI bleed patient, specifically our protocol calling for the initiation and concurrent use of vasopressin and nitroglycerin, right? So of course, first off, we think about the vasopressin dosing that we use. If we're talking a hypotensive septic patient, we're only doing 0.04 units a minute, right? Versus for this GI bleed patient, we're using astronomical doses by comparison, 0.2 to 0.8 units a minute. That's a whole lot of vasopressin. And then we're still going to combine this pressor with a nitro, with a drug that's going to lower blood pressure. We know that these are usually extremely sick patients, usually very hypotensive, requiring some pretty significant resuscitation. Why would we want to lower their blood pressure? The answer is we don't, right? And at this point, we've been talking about this long enough that you probably know that by now, and I'm just repeating old news. It's the point of this video. But we're not trying to lower their blood pressure. What we are trying to do is give them extremely high doses of vasopressin, because that is specifically going to target arteries and vasculature within the gut, within the GI system. But the unfortunate side effect is that it also has a very untoward and severe effect on the coronary arteries. So both the coronary arteries and the arteries in the gut have a much higher density of vasopressin receptors than the rest of the arteries throughout the skeletal muscle and everywhere else in the body that we're normally trying to control for blood pressure. So at those higher doses of vasopressin, you're not going to see a huge blood pressure response beyond what you get at that initial 0.04, but you are going to get almost a linear constriction of the gut arteries, the gut vessels, which is the whole point. We're trying to limit blood flow to the gut to stop the bleeding, right? It's not a long-term solution because now you're not perfusing the gut, it'll die eventually, but it is enough to stop hemorrhage until we can get them to surgical intervention. Of course, the other side so that's a intended benefit of the high dose of vaso. The unfortunate benefit is that that high dose of vaso is going to cause very severe coronary constriction. So in a patient with an otherwise healthy heart having an upper GI bleed, which chances are if you're cirrhotic and having an upper GI bleed, your heart's probably not the best, not the point. Even in an otherwise healthy heart, we can induce a myocardial infarction just from super high doses of vasopressin constricting those coronary arteries. So that's why we have to have the nitroglycerin anytime we're doing this high dose vasopressin. Of course, patients super sick, like I said, we know what these patients look like. They look like trash. They're trying to die on you. Start your vasopressin first. Give them the blood products, resuscitate them, get them up. But don't wait more than a couple minutes to then also get the nitroglycerin on the pump. If that does cause a decrease in blood pressure, manage it how you would anything else. Get the blood pressure up, right? We have other drugs. We have other pressors. If they need inotropes, then give them inotropes. If they need more fluids, more volume beyond what's in the blood cooler, give them that fluid in their volume. Make that clinical decision, and you decide how to fix the blood pressure. But pretty please don't forget the nitroglycerin, because there's no point in this patient having to go straight to the cath lab after they're done in IR getting their GI bleed thrombosed. That's really all I have to say for June. Like I said, RIP to Aaron. We miss him a lot. Hope he's doing well in PA school. We're going to move on. I don't think there's anything for July, so I think August was... Neil, the cameraman, is telling me. August was renal. So we're going to move on to talk about renal diseases. I'll be back in just a moment to talk to you some more about that. Deuces. So one more thing that I want to hit on, just kind of for everybody else listening, is the onset and taking the history of present illness, the HPI, for these patients can also really be helpful in diagnosing DKA versus HHS. And again, remember, the DKA is usually in a type 1 diabetic, and most of the time, this is actually how they get diagnosed. It's usually in younger patients, even kids, and they don't know that they're diabetic yet. So they think that they're living totally healthy, and all of a sudden they're feeling sick and they have some kind of flu symptoms or something. They just think it's a cold. And, they go to bed feeling sick one night and then they wake up the next morning completely messed up, or they don't wake up, right? And they're just found altered in bed. And it happens super, super fast within 1 to 2 days, because suddenly something happened in the body where, even though it lived 13 years kind of managing its type 1 diabetes, it just finally the pancreas completely crapped out and stopped producing insulin. So it happens really quickly. Versus HHS is usually in someone that is managing their diabetes someone with type 2 diabetes. They know that they have it. And like our patient, for example, she's doing all the things to manage it. She's taking her metformin. She's eating her good carb healthy diet, trying to take care of herself, checking her blood sugar multiple times a day. But then it's usually some kind of stress event that causes this to happen. Like, for example, that upper respiratory infection that she had about a week ago. And so then HHS is something that usually progresses more slowly. There's an initial insult that happens, and it takes days up to about a week for the HHS to fully develop and to present with that altered mental status and the symptoms that she was presenting with today. So the onset of it and how fast it happened can be super helpful in diagnosing DKA versus HHS. Long story short, rapid, something that comes on super quick, DKA. Something that happened very slowly over time, and there was some remote stressful event like an infection, more likely getting yourself onto HHS. So you can already have a pretty solid idea before you even get labs, which is super helpful for us if this is a scene call, right? Right. If we're running this as a scene call, picking them up right here on the pad here at Terrell, we're not going to have labs. We're not going to know the serum osmo. We'll know glucose. Sure, we can check the blood sugar. But we're not going to know anything else but the history of the patient, of their meds and their medical history, but also how long this has been going on. Super helpful information.
So that was a clip from September's education where Herb and I were talking about the management of patients with DKA or HHS, which of course stand for diabetic ketoacidosis, or hyperosmolar hyperglycemic syndrome. Almost messed that up. So really that was about how to really be able to tell just based on history. If you don't have lab values available, like you're running an unresponsive patient with an altered mental status patient with a high blood sugar on a scene call, right? That's all the information that you have or that you're going to get beyond maybe a little bit of history. If you can know if they're type 1 diabetic or type 2 diabetic, that can help you differentiate and diagnose the differences, differentiate between the two diseases, right? Otherwise, the management of them is almost entirely the same. The main goal, first and foremost, is always going to be rehydration. Prompt initiation of IV fluids is the most important thing you can do for either of these patients because they're going to be extremely volume down. They have been urinating and having insensible water losses for a couple of days or up to a week at a time, depending on if it's DKA or HHS, right? One's fast acting, one's slow acting, or slow onset, I should say. So first and foremost, get those fluids on board. Then we're going to start assessing for hyperkalemia, abnormal potassium levels, or abnormal levels of other electrolytes, right? In the case of HHS, you're going to have abnormal osmolarity. Sodium levels are going to be crazy. Potassium levels can be crazy. All of your electrolytes can be abnormal. Massive concern there with hyperosmolarity, aside from just poor perfusion and intracellular volume being down, is a concern also for cerebral dehydration. But then as you resuscitate them, there's also the concern for cerebral edema. So as you're resuscitating the patient with HHS, you want to do so very slowly. You still want to get all the fluids on board, but our goal is not to lower glucose or sodium too rapidly, because that rapid shift in osmolarity and serum osmolarity can cause cerebral edema and can cause lifelong, potentially devastating neurologic deficits, all right? So we want to do this all in a very controlled, very methodical manner. With either patient, if they present as hyperkalemic, either you do have lab values or you're diagnosing this, based off other findings such as an EKG or whatever, and you have insulin available to you, and you want to treat that glucose. Of course, this is mostly going to be interfacility transfers where you have insulin available. You want to make sure that you know the potassium level. I highly recommend do not ever initiate insulin therapy for a hyperglycemic patient, no matter how acidotic or how hyperosmolar or whatever the problem is, if you do not know the potassium level. Because if their potassium is actually normal and you're giving insulin for the sugar, not the potassium, once you take that potassium, you're going to have some pretty severe problems on your hands. The heart is not going to function. We call that asystole. It's a bad day. If you have a potassium value and it's low, Low is typically considered less than 3.3 or 3.5. Don't start insulin then either. Wait until they replace potassium. Either the sending facility will be able to send you with some IV potassium that you can replete yourself, or just wait till you get to the receiving facility where they can replace it themselves as well. Typically speaking, in a hospital environment, we're replacing potassium above 4.5, and we're doing so continuously. Even though the high end of normal is 5.1, we're trying to get close to that for the duration of insulin therapy, because hypokalemia can be just as detrimental as any of the other electrolyte abnormalities that they're already experiencing. If you find yourself, we all know the mantra, do not intubate a DKA patient. Now, it's not like the intubation process or being intubated is in and of itself detrimental to a patient with DKA or HHS. We're going to use these interchangeably from here on out, okay? The major, but especially actually with the DKA patient who is acidotic, whereas the HHS patient may not be, so I guess not interchangeably in this case, it's not like intubating them is in and of itself detrimental, more so than intubating any patient for any potential reason, right? The concern there is that by inducing them using paralytics and then continuing sedation, we're going to take away their spontaneous respiratory drive. Chances are they were maintaining their own high minute volume, right? So if you need to intubate a DKA patient because they're unresponsive and it's appropriate to do so, then do so, right? That is a decision for you to make, and that is a totally okay and well-supported decision. What you do have to make sure, like I talked a little bit ago over on the other side during January's education, is that you're probably not going to give them a normal minute ventilation, all right? So don't put them on the ventilator and then say, oh, well, normal minute ventilation is 4 to 8 liters a minute. I have to keep them within 4 to 8 liters a minute. You should know, and you should have end-tidal from before you even intubated this patient, showing that it was low, and you should try and match that end-tidal level pre and post-intubation, right? So if pre-intubation, they were breathing super fast and they had a spontaneously high minute ventilation with an end-tidal of 23, just ballpark, random number, let's say theirs was 23, then you can assume that there is significant metabolic acidosis going on that they're trying to compensate for, right? To maintain a somewhat normal pH. Just try and target the same thing once they're on your ventilator. Change your respiratory rate, change your tidal volume, get that minute ventilation up until you can match what their end-tidal was pre-intubation. Intubating DKA can be safe and can be totally clinically appropriate as long as you remember that there are certain ventilatory parameters that we have to be willing to break normal on to keep the things that matter normal, which is oxygen, CO2, and our pressures, right? And then byproduct of CO2, of course, being pH. Very last thing from that month, done with DK and HHS now, was just from the management of sepsis in the septic patient. And that was just an update in the Surviving Sepsis campaign guidelines that came out in 2021, updated from 2016. And that is how we should be using the lactate number. When a patient presents to the hospital with an elevated lactate from sepsis or from any other sources of malperfusion, that is an indicator of how poorly perfused they have been in recent hours. But it is a number that we should use to help guide an initial diagnosis, but not necessarily to guide therapy. So once we start fluid resuscitating these septic patients, our goal is not to continue resuscitating until lactate is within normal limits. Our goal is to start resuscitating to the point that they perfuse and start performing aerobic metabolism again, and hopefully stop producing lactic acid. But we should not be fluid resuscitating to a goal of lactic less than 2. If you arrive at a hospital and their initial lactate was 14, and they got their 30 mils per kg of fluids, and now their lactate is down to 6, that's not an indicator for us to give more volume if there's no other signs of intravascular dehydration, right? The lactate is downtrending, it's improving. There is no need for us to try and get it down below 2 or whatever you consider to be a normal limit. That's all I've got for August for renal diseases. I really appreciate Herb's help that month. He did a great job with that. He's doing a great job with current November's OMI stuff, and we'll be seeing more of him soon. Next up is going to be September, talking about ultrasound. We're almost done. See you guys in a minute. So September was ultrasound, right? And for starters, for introduction, we just went over how to perform a few key exams, and pretty simplistic. And we just want everyone getting practice with operating the machine, operating the app, and then finding those views in those windows. Pretty simple diagnostic tools that you are more than welcome to be using. We highly recommend that you do start using those on live patients on real calls to help you make certain diagnoses, help you identify certain problems. Otherwise, coming up in February and March, we're going to introduce some more advanced protocols, more advanced ultrasound processes, POCUS processes to further aid our diagnostics. Most of these are going to be more useful for the medical patient, the ICU patient, rather than actually in trauma, where I feel like a lot of us tend to think POCUS is most applicable. Really, most of the utility for it is going to be in that medical patient, that sick ICU patient, or sick medical patient coming off the scene. So keep an eye out for that coming up in February, March. Watch these 2 videos here for a refresher on how to perform our ultrasound exams. And
How to perform subsiphoid ultrasound. Step 1, add jelly. Step 2, slide down sternum until probe drops below xiphoid. Step 3, lay flat and scoop under xiphoid. Point probe a little to the patient's left. Scan until you identify cardiac function and rule out pericardial effusion. How to scan for pneumothorax. Step 1, jelly. Step 2, identify landmarks. Step 3, enter M mode and find a rib space. Determine whether you're seeing seashore sign or barcode sign. How to look for B lines showing pulmonary edema. Step 1, jelly. Step 2, identify landmarks. Step 3, scan at least 2 lung fields looking for comet tails. You need at least 3 plus B lines in each of 2 or more lung fields to diagnose pulmonary edema. Remember, once you've seen 1,000 normals, the abnormals will stick out easily. How to assess IVC collapsibility. Step 1, from subsiphoid view, rotate probe marker towards feet. Step 2, differentiate aorta from IVC. Remember, aorta is on the left and firm, IVC is on the right and wavy. Find where the IVC joins the right atrium. Step 3, have patient sniff or cough while watching to see the IVC collapse. How to scan Morrison's pouch for signs of intra-abdominal hemorrhage. Step 1, start at the right 10th intercostal space, mid-axillary line. Orient your probe so it's parallel with the bed. Step 2, slide through the intercostal spaces and anterior posteriorly until you find the liver-kidney interface. Morrison's pouch is usually not below the ribs like most people think. Make sure you start over the ribs. Step 3, look for a collection of fluid between the liver and kidney, a positive finding suggesting intra-abdominal hemorrhage.
All right, guys, we're just about done. This is it, the last month. It is the current month that's currently going on. November's topic was over OMI, occlusive myocardial infarction. You're watching that education now, or you just wrapped that up. So I just want to remind you that the purpose of introducing this is it's a fairly new concept in the whole world of cardiology, not just EMS. And that is that up to 40% of patients that have NSTEMIs that present with chest pain but no ST elevation on 12-lead EKG, about 40% of them are actually still having myocardial infarctions requiring cath lab intervention. So we're introducing this OMI concept to you all. Maybe you've heard of it, maybe you haven't. It's definitely more complicated. There's a lot more learning involved than just recognizing ST elevation on a 12-lead, but it's going to be absolutely critical, absolutely crucial to recognizing when a patient is having a true myocardial infarction requiring cath lab intervention. We will, of course, be continuing part 2 of that, either in February or March. February and March are either going to be, one of them is going to be part 2 ultrasound, one of them is going to be part 2 EKGs. So I recommend you all look forward to that, as I'm trying to figure out what to do with my feet here. I appreciate you all joining me. I'll see you back here next year for how to work on a tail rotor assembly. Appreciate you all, and happy holidays.